Thank you. Thank you for the opportunity to present some of our data. So I'm going to talk about clinical and virologic outcomes among kids and adolescents receiving care in a public sector clinic. And the nice thing about this is really and truly a public sector clinic, publicly funded, etc., and gives a glimpse into outcomes and care among children and adolescents. And I think, as all of you know, the provision of HIV care in the public sector is challenging. We have made a lot of accomplishments, but it does remain challenging. And successful outcomes will require lifelong retention and adherence, which require quite a lot of effort and resources. So we wanted to look at a public clinic and look at the outcomes among kids and adolescents. And we did a retrospective analysis of children enrolled in care, so children between the ages of 0 and 19, enrolled at Paranatua HIV clinic between 2004 and 2011. And to determine the clinical virological outcomes among kids in care, we did a cross-sectional analysis of the children and adolescents who had been on ART for at least 12 months. Viral load testing was not routine at that time, so we did viral load and CD4 and did a genotypic analysis of isolates in kids who were failing therapy. We subsequently did a follow-up, but I won't talk about that this afternoon. So that's the clinic, and it was established in 2004 by Dr. Bwakura for the pediatric clinic and Dr. Ndlovu for the adult clinic. And it merged to a family care model in 2006. It's affiliated with a teaching hospital, the University of Zimbabwe Medical School. Children enrolled in care required at that time 2 caregivers for ART initiation. Pre-ART counseling as well as continuous counseling was provided. Medication, CD4 testing are provided at no cost to the participants. And as I mentioned, viral load testing was not available at that time. So we looked at 2,293 children and adolescents who had been enrolled since 2004 to 2011. We extracted data from paper charts and did a double entry system. We have fortunately moved away from the paper chart system because not just the kids are in the clinic. Overall, we've registered almost 20,000 patients, so paper charts are a bit unwieldy. So we looked at the demographic characteristics of the kids in care, and a few things came through. So first of all, children are enrolling into care quite late. So a lot of the kids that we are taking care of are kids who are survivors of perinatal infection. So the median age of enrollment was almost six years old. Only about a quarter were enrolled before age 2. And over the period of the study, we didn't see any significant changes in the proportion of infant enrollments. Gender distribution was relatively equal, with a slight increase at the time of adolescence. The mom is the primary caregiver for half of them, and again, sort of decreasing as the kids became older. And over half of the children presented with late-stage disease, and you can see from the median age, it's really mostly perinatally infected kids who are surviving. And so to look at outcomes, we were thinking about the treatment cascade and interested in looking at engagement and retention in care. And so we looked at early program attrition, and we defined that as children who enrolled in care and within 3 months in care had dropped out of care and were lost to follow-up. And we called those kids linked but not engaged in care. We were struck to find that about a third of our patients dropped out of care within the first 3 months of enrollment into the clinic. And when you looked at the characteristics of the kids, the infants were the most vulnerable to being linked and not engaged in care, so really dropping out of care pretty early on. Being very sick and immunocompromised, so history of TB, WHO, advanced clinical stage, low weight for age Z scores, were all factors linked to being linked in care but not retained. And we don't really have a system where we could tell whether the kids had died or moved somewhere else. But given the findings, we suspect that given the advanced stage of the kids, a lot of those drop-offs are due to mortality. And art initiation actually reduced the likelihood of being linked and not engaged in care. We then looked at retention and factors associated with 12-month retention, and certainly things like severe immunosuppressions of age-defined WHO criteria, pulmonary TB, WHO clinical stage, again malnutrition, and not being initiated on ART were significantly associated with not being retained in care at 12 months. And art was very important, and so sort of following on Rashida's talk this morning, when we looked at kids over the 5-year period, long-term retention was very associated with being on art. So perhaps we should just put every kid who makes it into the clinic on art, just as a retention factor. It is a very useful thing to do. Lastly, we looked at successful outcomes on art and did a cross-sectional analysis of 702 children who were actively in care. The median age was 11. Mom was the primary caregiver for most of the younger kids and significantly not in the older kids. Of note, severe immunosuppressions of age-defined was evident, particularly in the older kids, and a history of TB was quite common at the baseline enrollment. And then looking at follow-up, so most of the kids initiated art at a median age of 8. Kids were mostly on art for about 3 years at the time of this analysis. CD4 percentage, the striking thing was particularly among the older adolescents, and this corroborates some of the data coming out showing that there is high mortality in adolescents. Even the ones in programs on art, we still see high rates of immunosuppression and low CD4 counts. Height for age Z-scores were also quite striking, and you see that in the clinics, the adolescents are typically short and stunted and have poor growth for their age. Most of the kids in this cohort were on a D4T-based regimen. This is obviously historical data, and only 9% were on PIs. We then looked at virologic failure, and the overall failure rate was around 31%, and particularly elevated in the adolescents, the older adolescents aged 15 to 19, where we noted a 40% failure rate, and we defined that as a viral load greater than 1,000 copies per ml. We then looked at drug resistance mutations, and about a third or 30% of the kids had no significant clinical mutations on sequencing, and 71% had some sort of clinically significant mutation. And in some respects, this is good because about 30% of your kids, good adherence, support, etc., can help them stay on the regimen that they're on, but a significant number do need to switch art. So finally, success of public ART programs is really threatened by this problem of early program attrition. So we really need to get kids into treatment very early. So avoiding kids coming into care at median ages of 6 years old. And I think as the PMTCT programs strengthen, hopefully we can start to see more kids coming into care in infancy. Long-term retention rates are a problem, particularly in kids who are not initiated on ART. And so I personally would advocate for universal pediatric adolescent ART initiation, not just for retention, but for other factors as well. And we are seeing high virologic failure rates. They're comparable to what others have described, but have been striking, and for us as a clinic have prompted us to think about how to improve care for adolescents. And lastly, just to point out that adolescents are a growing population in sub-Saharan Africa. We're a very young continent, and we will continue to be a young continent. So providing care to adolescents, whether with HIV or without HIV, should become a very high priority. So lastly, I'd like to thank everyone who has been involved, Dr. Bwakura, who's the pediatrician at the clinic and really is central to everything that happens at the clinic. Janneke van Dijk, who has been a great addition for us in the last year and a half and has really helped us to try and address some of the issues we've identified in the adolescents, and various students, collaborators who've been involved in the genotyping assays, etc. And funding was through USAID and PEPFAR.